Okay, I think with that, we will move into our patient disease education programming. And our very first presenter today is Dr. Simon Hanft. And he is a board certified neurosurgeon specializing in the care of brain tumors and tumors involving the spinal cord. He is the section chief of neurosurgical oncology for the Westchester Medical Center Health Network. He grew up on Long Island and received his undergraduate degree from Yale before obtaining his master's at the University of Cambridge in England. He attended medical school at Stanford, during which time he received a prestigious Howard Hughes Fellowship to study neurostem cell networks. He went on to complete neurosurgery residency at Columbia Medical Center and the Neurological Institute of New York, followed by an additional year dedicated to brain tumor surgery as a surgical neuro-oncology fellow at the University of Miami. He then joined the faculty at Rutgers Robert Wood Johnson Medical School and developed the most active brain tumor practice in New Jersey. He has contributed to multiple peer-reviewed publications, including operative videos demonstrating surgical technique. He is an author of 5 book chapters on brain tumors, 2 book chapters on spine tumors, and the Medscape entry on brain surgery entitled Craniotomy. He is also the lead editor on a published textbook entitled Tumors of the Spinal Canal. He has twice been recognized as a top doctor for New Jersey Monthly Magazine, and he received a medical advisory award by Voices Against Brain Cancer, one of the leading national charities for patients with brain tumors. He has over 500 verified patient reviews on health grades, which makes him the most highly reviewed neurosurgeon in New York and in the top 1% of doctors nationally. Wow. Okay. We can't wait to hear from you, Dr. Hanft. Are you there?
Not only am I here, but now that you rattled off all these credentials, I feel bad we didn't invite my Jewish mother to join this webinar here.
So do I.
Yeah.
Next time. How are you?
Thank you. Thank you so much for that.
Thank you for joining us, sir.
Yes, I'm going to share my screen. I think that's
Okay.
probably going to be the best.
That sounds fab.
So first of all, again, thanks for all of that. It's greatly appreciated. I want this audience to know that this is really a unique opportunity for me, and I'm thrilled to have this platform because, as you might imagine, the overwhelming majority of the time we're giving any type of talk about what we do, it's often to people in our field or people who have some relationship to the field, and it's not often that we get an audience with patients, survivors, really the people that we actually are attempting to treat and help. So this is a very unique circumstance, and I'm greatly appreciative of the opportunity. What I'm here to talk about today is a technology that's become quite near and dear to me, and I've become really a devout user, if you will, of it. It's called GammaTile. And as I'll get into in the coming slides, it is a type of brachytherapy, which is it sounds very novel, but is a long-standing technology whereby radiation is implanted in the surgical bed after tumor removal. Interestingly, it's something that we see in other fields outside of brain surgery. So you may have heard of its application in prostate surgery, for example. And there is quite a history and prologue to GammaTile in terms of use in the brain, but this, in my mind, represents a clear technological step and advance, and that's why I am quite enthusiastic about it and eager to share some of the details with you today. We don't need to go over this again. So just to give you guys a general overview of what we're dealing with, glioblastoma, though somewhat rare, we're still talking about over 15,000 new cases a year, and in the United States, and then when you add the number of metastatic tumors to the brain, you're getting close to 250,000 new patients, new diagnoses annually, and as we're starting to see longer term survivors in the cancer world, that gives more of an opportunity for cancer to spread to the brain. And so we're seeing an increased incidence of metastatic involvement in the brain, which is an unintended, but in a way, a good consequence of the fact that we are seeing longer term survivors, primarily due to advances in immunotherapy. One of the fundamental challenges with malignant tumors in the brain is what you see here, which is that there is a high rate of recurrence. That's what truly makes these malignant entities, that it's not so much that they cannot be removed completely or what have you. It's just that the likelihood of regrowth is extraordinarily high for various reasons that I don't get into in this particular talk, but there are a host of reasons as to why these tumors come back. And so one of the main challenges we have as surgeons and oncologists and radiation oncologists is to prevent recurrence, because obviously when there's recurrence, that impacts patients in multiple ways, functionally, and most importantly, survival-wise. So you can see here that in general, over 40% of patients who undergo resection of a brain metastasis experience a recurrence of that metastasis, so a high number. And on top of that, there is a phenomenon fairly common of rapid recurrence, such that after you remove the tumor, it may grow back over the course of days into weeks into basically what you had just removed initially. And we see that in some particularly aggressive types of brain cancer, especially glioblastoma. And there's also an entity known as meningioma, which is not classically referred to in any way as malignant, but there are more aggressive types of meningioma that vault it into that category, where recurrence can be a very difficult thing to deal with. So what is one of the strategies that we utilize to prevent recurrence after surgery? And we'll get into that in a little bit, but just giving you guys a quick overview of how these tumors look on MRIs. So we see here all the way to the left, we see what's called a low-grade glioma, and that's typically in one of two categories, referred to as either an astrocytoma or an oligodendroglioma. To the MRI image just to the right of that, which is the second image in the sequence, we see more brightness within the mass. That's contrast uptake. That's more indicative of a high-grade glioma, here glioblastoma. To the slide right, to the right of that, we see a meningioma, different contrast pattern arising from the surface of the brain. And then you see a fairly typical pattern of brain metastases, smaller, though they can be very large, scattered, both hemispheres, different locations. And so these are very common appearances of what we deal with surgically and also in terms of radiation. In general, the basic concept is this: we remove as much of the tumor as we safely can. Even if we remove everything that the MRI shows, we know that there's microscopic disease, infiltrative projections, if you will, that escape our ability to detect even with magnification intraoperatively, as well as MRI. So we know that that patients undergoing these operations will benefit from radiation to the surgical bed. We know that that will prevent recurrence in some cases completely, or at least delay the time to recurrence. Traditionally, that radiation is delivered as what in the form called external beam. There are many variations on that, but that very basic idea is that you basically stick your head into one of these machines, and the machine delivers radiation externally to the target. And the variations on this range in terms of the radiation platforms that are utilized, the specificity of the radiation, sometimes even the type of radiation, whether it's photon or something you may have heard of more, that's becoming more in vogue, proton. And invariably, that radiation happens a few weeks after the operation, primarily because you want the wound to heal, but you also want the patient to recover a little bit from that surgery. But as you might just develop a sense, either having gone through it or just hearing me talk about it, seems like a delay is probably not the best idea when we're talking about malignant disease that grows fairly rapidly. And so that's where the concept of brachytherapy really enters the equation, where we're talking about delivering a form of internal radiation, not the external beam, but radiation that can be implanted at the time of surgery and begin acting immediately. GammaTile, in my view, is the most refined and advanced form of that technology. To describe it in general terms here, it consists of 4 very small seeds that contain the radiation. They are spaced out within that bioresorbable collagen tile that you see displayed there in the forceps. It's basically a postage stamp in terms of size, and that's the analogy I use for patients. We implant these right at the time of surgery. So in your mind, envision the act of removing a tumor. There is a cavity where that tumor was, and along the walls of that cavity, as you might suspect, despite our best efforts, there is typically microscopic disease. And so we line those walls with these tiles. That way, immediately, radiation is delivered to the walls of the tumor and whatever residual cancer cells may be there, thereby killing those cancer cells and lowering the likelihood of recurrence, or at least delaying the time to recurrence. There are also other benefits of it. We have emphasized here on this slide the immediacy, which obviously has benefit because we don't want to delay, but also the convenience of it for a patient to have basically the surgery and radiation done in one sitting, as opposed to having to come back weeks later, which can be very problematic for certain patients who may live alone, who may live an hour and a half from our medical center, or whatever the case may be. Typically, we have to repeat an MRI before the scheduled radiation treatment because things have changed. The cavity has evolved. So these things, these logistical considerations are also eliminated by the fact that we can lay down this GammaTile at the time of surgery. In addition, we're not dealing with hair loss, which is something that we often see in some of the radiation treatments that we prescribe. And it's a much more targeted field because it's delivered at the time of surgery under direct visualization, as opposed to repeating an MRI a few weeks later and having to trace out what can become a more challenging cavity to define in that setting. So benefits of the therapy, again, we've gone over this just over the last minute or so, but we as neurosurgeons can place these tiles at the time of surgery exactly where the tumor existed. And so we have that real-time validation and verification of putting these tiles exactly where we know the tumor once was. It's very targeted because of that. And so in the areas where the tumor is most likely to recur. And for that reason, it's much less likely, I should say, to damage the surrounding normal brain. And that's always the push-pull of the surgery that we perform. We want to get as much of the bad out while preserving the good. And in some parts of the brain, we have liberty to do that. But in other parts of the brain, we don't. And so using something like this, especially in those areas where we know we're coming up against some critical functional tissue, is a nice advantage. And then this is something that you really, with very few limitations or restrictions, can go about in your daily routine after having this implanted. So who are the candidates for GammaTile? So it's FDA cleared broadly, the indication for newly diagnosed malignant tumors and recurrent tumors. I think one of the beliefs commonly held among neurosurgeons and radiation oncologists is that this is more of a recurrent therapy. But as you could tell from how I've described it, we are often utilizing it. In fact, that is my strongest indication for when we're first encountering these tumors. That's when we want to really kick the tumor while it's down. But of course, in the recurrent space, it has major advantages as well. So this technology is for patients who require brain tumor removal. That is not every patient. There are times where the tumor may be small enough that the patient can benefit from some form of targeted external beam radiation only. Okay, so a necessary precondition to GammaTile may seem obvious, but bears repeating. The patient has to undergo surgery. They have to undergo surgical removal in order for the GammaTile to actually enter into the equation, physically enter into the cavity. So we're talking about newly diagnosed malignant brain tumors. We're talking about recurrent brain tumors, malignant, but also you'll see there listed recurrent meningioma, which is oft viewed as a benign entity, but can recur in ways that can make it behave basically just as bad as any type of malignant brain tumor. So this is the kind of technology that if you, a friend, family member, what have you, has this kind of, any of these kinds of tumors, this could be a therapy that's available to you. I'll go quickly over the clinical studies, which are very promising. You could see up here at the top at major institutions nationally. These are really some of the big name players in oncology and neurosurgical care. You could see that the success with treating recurrent, previously irradiated metastases. So these are patients who have undergone radiation and then get surgery to remove this failed tumor, failed in that it's still growing despite the radiation. And then the GammaTile is lining the cavity after that. These are very high success rates in terms of control. 80% at 12 months of no regrowth at the Barrow. Sloan's paper quotes 92% of patients no regrowth at 12 months. And at the Miami Cancer Institute, borderline hard to believe, but 100% of the patients they reviewed, these are relatively small sample sizes. For newly diagnosed metastases, which is the space that I've gotten most involved in, University of Minnesota, which has been a very big user of GammaTile, show a significant percent of local control at 6 months using GammaTile. So very promising features. For recurrent glioblastoma, Miami also shows, as well as along with their newly diagnosed metastasis series, significant progression-free survival. That's what the term PFS refers to, OS refers to, overall survival with resection and GammaTile compared to those patients who are not receiving GammaTile. So we're seeing very promising early numbers. The numbers aren't even so much early anymore because the technology really has been available now getting into the 6+ year range. So I'm happy to expound on this a little bit more. The emphasis of my talk, I think, was a little bit less pure kind of clinical result and more about kind of what this is about, who may benefit. There are ongoing clinical trials that we also very much encourage patients to get involved with. And as I tell patients, some of these trials may directly benefit you, but I often find that patients feel when they're afflicted with these tumors, a real humanitarian urge to help future patients. And that's often what these trials will do in collecting this critical information about patients who undergo these operations and receive GammaTile, that it can help us figure out how best to use this, refine this, and who really can benefit from this in the future. So we now are seeing GammaTile in over 100 hospitals across the country. Was brachytherapy in the brain was a very niche endeavor. This is just a tribute to the fact that it is really expanding, and I think there's a lot of enthusiasm among neurosurgeons and radiation oncologists who are partners in this, with almost 1,500 patients treated with this to date. So it's really ramping up. And you know, I'm happy. These are just some general comments about the technology, and I'm happy to take any questions from any of you here. And thanks so much again for the forum.
Thank you, Doctor. If anyone does have a question, you are more than welcome to ask a doctor right now, or you can type your question into the chat box and I will hopefully get to it. One of the questions that has come in, we have a lot of people actually joining us from the UK, Germany, but also Canada today, as well as all over the United States. When will this treatment be available in Ontario, Canada?
Yeah, you know, I should know the answer to that, but I just don't. It's a simple thing for us to figure out. I just probably have to ask one person at the company so we could get that answer to you. I don't know if anyone from GammaTile is on, whether or not they can answer that.
Yeah, there's a few people from GammaTile on. Does anyone have the answer to that question?
Hi, Delanne. This is Lori. No, at this time, we don't have any plans in place to expand to other countries. Like Dr. Hanft mentioned in the presentation, we are in over 100 hospitals right now, but there's still so much to cover within the US that we're really laser focused on getting into more hospitals and helping more patients in the US at this time. As soon as more information is available, we'll be sharing that when we're going to go out of the US.
Thank you, Lori. Thank you.
I see a question here in the chat
Yes.
about GammaTile relevant for multifocal tumors. This is a great, really advanced question. It depends a little bit on what type of tumor we're talking about, so I'll tackle it from two angles. If we're talking about multifocal glioblastoma, the answer to that is typically going to be a no, because GammaTile, at the end of the day, is a what you can regard as a focal therapy, and a multifocal glioblastoma is, as you might imagine, a more diffuse process. So it's not typically utilized in that circumstance, especially since, just think about it from a very kind of literal, practical standpoint. We're removing tumor in one spot and laying down GammaTile, and then those other spots we're not necessarily operating on those spots. But let me tell you how it may apply beyond glioblastoma in metastases, which are often multifocal, if you want to use that terminology. There are times where I will remove in a patient, let's say, who has 3 or 4 metastases. If there's a dominant metastasis in terms of size, swelling, and symptomatology, I will remove that and line that cavity with the GammaTile, and then subject the other non-surgical tumors to more standard radiation. So that is kind of a, if you will, a hybrid circumstance where you can still utilize the GammaTile and external beam. And there are reasons to do that. Many of the reasons which I laid out earlier, we still believe that the power of the GammaTile, the immediacy of that treatment, is significant enough to warrant its inclusion and removal of a metastasis in a patient that has other metastatic tumors as well.
Thank you. There's a really good question in the chat box. Jenny just posted it. Do you see it?
Yes. What is your recommendation for clinical trials of GammaTile and exclude? Yeah, it's a good question. You know, these are one of the things that we deal with for newly diagnosed glioblastoma, particularly maybe something you guys have heard of here, known as Gliadel. One of the deterrents for Gliadel, which is something that I'm not saying anything negative about, I just haven't incorporated into my practice, but I know one of the deterrents over the years has been, if someone has Gliadel placed at their index operation for glioblastoma, it can be an exclusion for future clinical trial enrollment. And that is a deterrent for both neurosurgeons and patients, obviously. It depends on the circumstance. I personally, and we're talking here about high-grade gliomas, I am not utilizing GammaTile much in the upfront glioblastoma situation. There is a trial, which I had on the slide before here, known as Gestalt, which is looking at that. And there are people who do utilize it for that. It hasn't been my application of the technology to this point. So I've not run into what this person is really asking about very intelligently here. Now, if you're asking about in the recurrent setting, right? So there's a recurrent glioblastoma, you put in GammaTile in that patient and potentially exclude them from a clinical trial. Well, I will tell you that, yes, nearly automatically, if you are putting in GammaTile or even not, you are taking that patient out of some type of clinical trial. So you have to consider what the clinical trials are, what that patient could potentially qualify for. And there are going to be circumstances where you feel that GammaTile might be a superior option to a patient just getting recurrent surgery and enrolling in a trial. It's going to be something that you have to weigh with the patient, and invariably at that moment, the neuro-oncologist. So it can be a tricky thing to navigate, and that's why this is a very good question.
That's a very good question. Thank you, Doctor. Do you mind putting on the slide again that if people have questions, such as where can I have access to GammaTile, so that there it is. Awesome.
Yeah.
That's a really important link, a URL. I also want to mention, of course, our direct services team here at the End Brain Cancer Initiative can certainly help you identify the closest site to you, as well as make an introduction for GammaTile. So please utilize our services as well. I want to thank you so much. This was very enlightening to all of us. What we want to see is, prior to surgery, we want to see our physicians and our rad oncs having a conversation with patients who are diagnosed with of course, GBM, recurrent GBM, low-grade gliomas, metastasized disease, about GammaTile. What we don't want is for patients to learn about GammaTile after the fact.
Right.
So we need to get loud about that. There's a lot more disease education, awareness, and outreach around GammaTile that needs to happen. And I know there's a lot that GT Medical is doing with the healthcare provider population. But it is the patient voice that will also change practice. This is an FDA-approved treatment. However, we know a lot of people do not have access to it. So today's presentation was really appreciated, and I know it will increase access for this patient population. Thank you so much.
Happy to do it. I mean, look, you guys know this better than I do, right? You become your own best advocate, right? When you get this diagnosis, the people who are going to help you are yourself more than anybody, and obviously some family, and you almost become an expert in that disease. I mean, I have some patients who I feel genuinely know more about the condition than I do in certain ways. It's wild, but that's what it should be. And sometimes the process unfolds so quickly, it's hard for you to become an expert, especially being a non-medical people, so quickly. So that's why we have forums like this, and we try to spread the word as best as we can. And that's why I think, Delanne, what you guys are doing here is so critically important.
Absolutely. We really appreciate our partnership because it helps us increase the patient education, awareness, and outreach, which simply increases access. So that's kind of what we're all about. Okay, we must move on. That was an excellent presentation. Thank you so much.
Thank you. I'm going to try to figure out how to, yes. Did you get the screen back? You got it.
Yes, there is Dr. Haynes' contact information. Please feel free to reach out to him as well if you have additional questions. He's a great resource. Thank you so much, Doctor.
Thanks for having me. See ya.
Absolutely. Bye-bye.